Dr. Mario Sugar. How are you? Welcome.
I'm good.
We
I'm
have the
very
honor.
good.
Yes.
Thank you very much for having me. I'm really honored to be able to join your conference. I hope next year I'll be able to do it in person. This year I couldn't do it because my son was getting married, so I'm really happy about that. But anyway, in the next 15 minutes, we're going to talk about medical weight management. We're not going to focus on any surgical part of the management. So first, let's go through the definition of the obesity. We almost all know this. We use body mass index as a measure of the obesity. Body mass index is weight in kilogram divided by the height in meters squared. It is most acceptable measure of the obesity around the world, but it doesn't really, it's not perfect. It does not account for the body frame. So for example, if somebody who's very muscular might have a high body mass index, but low body fat content, and as opposed to some people who are relatively thin, they have low body mass index, but can have relatively high body fat content. So that's not ideal measure, but it is actually the one that we use the most. And then definition of the obesity is really BMI over 30. Now normal BMI is between 19 and 24.9. Once you go to 25 and 20 to 29.9, you are considered overweight. And it's important to understand this because some of these people will qualify for medical weight management. Once you're over 40, we consider you morbidly obese. And even if you're 35, but you have a comorbidity that is influenced by weight, such as diabetes, hypertension, and so on, then the morbid obesity is actually considered to be with the BMI of over 35. Now, what are the principles of the therapy? Well, it's caloric restriction. That's what it is. Actually, in the studies in the metabolic chambers, no adult patient was able to maintain the weight if he was eating less than 1,200 kilocalories per day. So really the key is a calorie reduction. How are you going to achieve this? Well, there's several things that you can do. But losing weight, once you lose weight, your body becomes smaller. So you require less energy, to maintain that new weight. And also your metabolism slows down, your basal metabolism, you become more efficient, thermodynamic machine. So if you make a change in your behavior, your lifestyle change, you start eating less, you start exercising more, you're going to achieve new kind of balance. You're not going to keep losing weight forever like many people expect. So with the lifestyle measures, it's kind of very hard to lose significant amount of the weight. Less than half of the patient in intense, lifestyle programs will lose 10% of body weight or more. And then, if they stop these things, it will weight tends to return. Now, when the people are morbidly obese or moderately obese, it is really unrealistic to expect that you'll be able to return to the normal perfect body weight. And the expectation of the patients are actually frequently unrealistic. So there's one study looking at the people who were losing weight and found that there's no one patient that study achieved their dream weight that they were aiming for, and only few are happy with the weight loss that they did achieve in the program. So this is the field of the medicine that is kind of thankless, field. I mean, we try to achieve as best results as possible, but patients are usually not satisfied. So what do we have to do? We have to actually set up the realistic goals of treatment with the patient. So for example, that would be a pretty good goal, like lose more than 2 kilograms in the first month of treatment, lose more than 5% of the initial body weight in the 3 to 6 months, and then remain on that level. That would be good enough for us. If you lose 5% of the initial weight, you reap the metabolic benefit. We know that for sure. So from our standpoint, from medical standpoint, from medical professional standpoint, we would consider 5% weight loss as a successful weight loss program. So this is it. So but the patients are usually not satisfied with this. They want to lose more. and that's the reason for this unhappiness with the patient. Now, what do? We can do the diet. We're not going to discuss the diet too much today because diet is as good as you can stick to it. It is calories, numbers, calories, calories, calories. It's hard to explain this to some patients, but it is that. Exercise is another thing you can do. But again, losing a lot of weight just by exercise is hard because you require a lot of exercise to lose significant weight. So, for example, 100-kilogram person needs to run about 2.5 marathons to burn energy contained in 1 kilogram of the human fat, which is between 72 and 7,400 kilocalories. So if you have to lose 40, 50, 60, pounds, or let's say 20, 30, 40 kilograms, it will be very hard to achieve that just by exercise. On the other hand, exercise is very good at maintaining muscle mass, maintaining the functional ability, and it does have, health effects beyond just weight loss. But again, we don't have time to talk about it today. And then there are medications, which is really the topic of today's talk. So medications are available, and they should be considered for the treatment of any patient who is over 30, who has BMI over 30, or even 27 if the comorbidities are present. Again, diabetes, hypertension, stasis, fatty liver, and so on. And it should be prescribed for the patients whose BMI is over 35. You should really prescribe it. Once you reach this level, medication should be introduced. And of course, this should be done after diet and exercise alone have failed to achieve the weight loss goals. And these medications that we're going to discuss are always, just in addition to diet and exercise, as an adjunct to the therapy. So what do we have in terms of the medication? In the United States, the FDA approved several medications. We have lorcaserin. I'm not going to go through the brand names because they might be different in Egypt and in Africa. So lorcaserin is one, orlistat is another one. We have a combination of phentermine, slight stimulants, and topiramate that is used in combination. Then we have phentermine alone. We have a combination of naltrexone and bupropion. And then we have GLP-1 analogs. Liraglutide is approved in a higher dose for the treatment, and semaglutide. Now, on my next slide, I'll show you those that are not approved by the FDA. Fluoxetine, but it can be used. Sertraline, bupropion on its own, topiramate on its own, zonisamide on its own, and then this last one, tirzepatide. Well, when I was sending these slides to you, it was not approved by FDA, but now it is. Tirzepatide is a medication that I want to talk in a little bit more detail later because it's very exciting. So, the most commonly used weight loss medication in the United States is actually phentermine. This is only approved in the United States for short-term treatment. Actually, here in Ohio, where I practice, we only can use it for 3 months. Because it is stimulant, there is a potential for dependence and abuse, although this risk is very small. I've been using this medication and I have not run into problems so far. It is controlled substance in the United States, so you have to be really careful with the prescription. But what it does, it actually causes significant weight loss. So you can see here, the study showing the effect of placebo in a study. Now you have to understand, every time you do the weight loss study, placebo arm will lose some weight because it's always associated with changes in diet and exercise. But you can see that it continuous phentermine and also alternate phentermine, 1 day phentermine, 1 day placebo, caused very similar weight loss. Now, this is all done for 36 weeks, which is actually a relatively prolonged period of time. We can't do this in Ohio. We have to do 3 months and then stop for 6 months, and then we can reuse it again. But the reason why it's heavily used is because it's cheap. It costs about $35 per month, and most patients in the United States can afford it. The other medications are more expensive, and they're usually not covered by insurance, so are much less used. Orlistat is the drug that is blocking fat digestion. So inhibits pancreatic lipase. This prevents the digestion of triglyceride to glycerol and fatty acids, so you cannot absorb them. So this could be excreted in a stool. Since the usual diet in the United States is about 30% fat, and about 1/3 is blocked from absorption, it will be result in decreased caloric intake and decrease in weight. Orlistat itself, it stays mostly in intestines. It is absorbed less than 1%. And as you can see here again, in the blue, there's orlistat, and you can see that there is actually improvement in weight loss in comparison with the placebo. Orlistat can be used indefinitely, and once you stop it, there is actually increase in weight. So orlistat caused the weight loss. If you continue, there was a little bit of weight gain, but if you switch it to placebo, there is a return of the weight. On the opposite side, if you do the placebo, there is some weight loss with the diet and exercise, but if you then started more orlistat, there is additional weight loss. Now, the problem with the orlistat is that it has a kind of unpleasant gastrointestinal side effects, and the people kind of tend to stop it over time. Lorcaserin, this is serotonin 2C receptor agonist. There was a previous serotonin agonists like fenfluramine and dexfenfluramine, but these were causing cardiac valve diseases, and they were removed from the market. Now, lorcaserin is specific to 2C receptor agonist. So these receptors are only present in the brain and not in the heart. And really, up to this point, in over 2,000 patients for up to 2 years, there was no evidence of any valvulopathy with lorcaserin. Now, weight loss with lorcaserin is about 3 to 5%, so it's not tremendous weight loss. There are some side effects, headaches, dizziness, and nausea. But as you can see, in comparison with placebo, there is a significantly better weight loss with lorcaserin than without. So it's a safe drug, it's effective, but it's not very powerful. Combination of phentermine with topiramate. Topiramate is a medication that's used for treatment of epilepsy, and it was during these treatments, it was noted that the people who are treated with topiramate do lose weight. Now, if you do the high dose topiramate, people will lose some weight, but there is actually mental confusion frequently associated with it. So in combination with phentermine, where you can use both drugs in a lower dose, there is a synergistic effect. So this combination gives the greater effectiveness with fewer side effects. There's some side effects, most commonly dry mouth. This is really what I've seen in this medication. These other things, numbness, tingling, insomnia, dizziness, anxiety, are really very, very rare. I have not seen problems with this. And as you can see, if you do the placebo and then phentermine in low dose with topiramate versus a little bit higher dose, there is actually dose response. And you can see the better weight loss in this combination, and also better weight loss if you increase the dose. It's a well tolerated and it's a good medication. Costed about a couple $100 per month, and since insurances rarely pay for it, patients usually cannot afford it. So those are the common medications that we use for treatment of the diabetes, of the obesity. Now, GLP-1 analogs are developed for treatment of diabetes, but they've been very effective in lowering the body weight too. They do have pretty good effect on glucose lowering because they increase insulin secretion in response to the meal, to the hyperglycemia. They decrease glucagon secretion, again, in response to glucose with hyperglycemia. They're glucose dependent. They delay gastric emptying. They increase in the B cell mass in pancreatic islets. There is a body weight lowering. There is delayed gastric emptying, but it's also decreased appetite. There is increased feeling of fullness and satiety. So we know that there is a central effect in the brain, and that leads to decreased food intake. And actually, this medication also has potential to, slow down or even stop the progression of diabetes, type 2 diabetes. So this is actually shown in animal models, but not in the humans yet. There's a lot of them. This is a lot of studies studying the native human GLP-1 infusion. As you can see, in all these studies, there was decreased energy intake. When you do the meta-analysis of these studies, you can see significant decrease in energy intake with GLP-1. The second GLP-1 analog that was put on the market was liraglutide. and then you look in treatment for type 2 diabetes, and as you can see, when you compare the people use of liraglutide with the use of the glimepiride, you can see that there is actually some decrease in the body weight with the liraglutide versus increase in the body weight with sulfonylurea. Hemoglobin A1C effects were very, very similar. So with these medications, we get the benefit of the weight loss and the same effectiveness of the glucose control. Now, liraglutide in a higher dose than is approved for treatment of diabetes, 3 milligrams. For diabetes, we use up to 1.8 milligrams. But if you do 3 milligrams, higher dose, then you can see that actually you can achieve the significant decrease in the body weight in comparison with the placebo. And that happens regardless of the presence of the diabetes. So people who have total normal glycemic control or those who have prediabetes has equally effective weight loss with the liraglutide, indicating that these medications should be used for the treatment of obesity even in the people who do not have diabetes. The other one is dulaglutide, which is should say that the liraglutide is given daily, once a daily subcutaneous injection. But now we have weekly GLP-1 analogs, dulaglutide, and as you can see the change in the body weight of the 52 weeks, you can see that there is a dose-dependent relationship. Dulaglutide for the treatment of the diabetes is right now approved up to 2 milligrams per week. But if you go to 3 and 4.5 milligrams, you have additional weight loss with these medications. This is a medication that's given once a week. The side effects are nausea, so we slowly increase the dose. Very effective for the treatment of diabetes. This is another study looking at another medication, semaglutide, 2.4 milligrams weekly, and you see the very similar things with the other GLP-1 analogs. You see that in comparison with placebo, there is a lot more weight loss with this, again, weekly GLP-1 analog. And then finally, I'm going to talk about tirzepatide, which is the newest medication on the block. It's been in the meantime approved for treatment of diabetes and obesity. It is developed as a single molecule, but two receptor agonist. It is a receptor agonist on the GLP-1 receptor, glucagon-like peptide 1, in GIP, glucose-dependent isotopic peptide. And so it's a double analog, and it's the first one and only one on the market at this time. And as you can see, when you do tirzepatide, this is again given by weekly injection. If you do it 5 milligrams per day, 10 per week, 10 milligrams or 15 milligrams per week, you have increase in body weight. But look at this extent of this weight loss. This is a percentage change. So you have at the low dose tirzepatide 15% loss of weight, of the body weight. You go to 10 and 15, and you have 21%. There's no medication that caused that. This is the best tool we had so far. This is comparable to bariatric surgery. And as you can see, this happens in relatively fast fashion. You can see first 24 weeks, you see 15-16% weight loss. But this weight loss continues as you continue using the medication. So up to 72 weeks from randomization, we do not see plateau at a higher dose of this medication. So this is incredible medication to be used right now. Of course, it is very expensive, but I love to use it. I was able to prescribe it to several patients. It's well tolerated. You increase the dose slowly. Nausea and vomiting are the side effects, but a very small number of people have it if you slowly increase the dose, start at 5, 10, and 15. So bottom line, conservative measures are actually good for non-morbid obesity. There's really no cure of obesity. It's like alcoholism. Once you're obese for life. There's no cure. There's just control. So you cannot, once you lose weight, the hard part starts. You know, maintaining the weight is the hardest part. Weight will fluctuate. It's not going to stay stable all the time. There is no need for disappointment when this happens. Patients should understand this. You have to educate the patient about principles of diet and exercise and the medications used. Diet is as good as patient can follow it. There's no diet that is better than other. You should advise the patient to exercise daily, not 3 days a week, 5 days a week, daily. And most of the patients who will be started on medication will require this medication continuously. They should not be stopped. because when you stop it, there is a regaining of the weight. Thank you very much. That is my last slide.